So welcome to today's Night's Watch discussion on The Incredibles, and then we'll also include Stephen King's Misery in this discussion as well. So for those who were able to watch The Incredibles, any particular character you'd like to start with? No wrong answer.
I feel like Syndrome would be pretty obvious.
So Syndrome's fine. All right. So with regard to Syndrome, what did you see?
Well, for Syndrome, he demonstrates aspects of bipolar disorder, and because of his very quick mood changes and also very extreme mood changes.
So extreme mood shifts, and therefore bipolar is a consideration. With regard to that observation, specifically with regard to the affective instability, clinical term we'll use to describe that, not that it's necessarily contained in the film, but what information would you like to know now? If we had Syndrome here, what would you ask him? Substance history, medical history. So for now, our patient, our fictional patient, tells us no and no. Right? Whatever specific questions you asked, he has denied use, and he denies any past medical history. What else do you want to know with regard focusing on his affective instability, his rapid mood swings? So I think the first thing, and we'll get to the idea of being clinically significant, but one of the first things the clinician should inquire about is a time frame. What is it that we're actually talking about? What is it that we observed? And what more information can the patient provide us that will allow us to kind of develop this differential diagnosis that's going to include a bipolar or related disorder? So first and foremost, I would want to know from Syndrome if he could qualify these shifts of mood, and along what time course are we talking about? And I think there's two levels to this. The initial level is when you feel up. How long does that last? And when it stops, can you talk to me about how that feels? And then where do you go from there? Do you go back to your premorbid baseline? You probably wouldn't use those words in the actual discussion, but do you go back to feeling quote unquote normal, otherwise referred to as euthymic? Or do you go in the opposite direction? Do you go from irritable to depressed or vice versa? And then how long does that last? And then if you begin to get that type of time frame, taking a step back, getting an idea of how often does this happen, right? You discussed the time frame with me that appears to go over 18 months. 18 months ago, was that the first time this happened to you, or are there prior occurrences as well? I mean, and what we often do in psychiatry, at least academic psychiatry, is we could use a dry eraser board and actually begin to map this out. Okay, what age or date, high, low, euthymia, and really then after teasing away what would be referred to as a past psychiatric history, take a step back and just look at the visual. What does it tell us? If the visual tells you that Syndrome has these episodes of irritability that last for at least a week and on average about 3 months, alternating with periods of euthymia or depression, themselves lasting a sustained period of time, that is very consistent with a bipolar or related disorder. If, on the other hand, we actually, number one, see more rapid mood shifts, like within a day, highs and lows within a day, that don't themselves build a timeline comparable to baseline functioning, then we're dealing with something else. Okay, and let me go through that one more time. If there are highs and lows that you mark from date A to date B, and they are themselves not a departure, a change from previous functioning, then you're dealing with something other than bipolar. If, on the other hand, even with highs and lows, if the individual, let's call him Syndrome, has highs in the morning, lows by noon, highs, after lunch, lows by dinner, high in the evening, and then cries himself to sleep at night. And those rapid mood shifts started about 4 months ago and continue today, or maybe ended yesterday. That demarcation shows that those highs and lows themselves are a change from previous functioning. They build their own episode. And that is often referred to as an episode with mixed features. And that is indicative of bipolar, right? So highs and lows that are rapid within 24 hours may or may not be bipolar. It depends if there is demarcation and therefore definition or defining it as a discrete mood episode. If it is a discrete mood episode that's a change from previous functioning, that could be a bipolar or related disorder. But if it is not, if you don't get those clear lines of demarcation, then there's probably something else. Do you have any clue, A or B, if either of these apply to syndrome? This is often tough when we watch a movie because we don't get to watch the prequel, especially since the prequel's never been made. So I'm going to take the silence as no. We really don't have a good firm understanding on whether A or B apply here. That means bipolar disorder has to remain in our differential. Now, we don't dismiss it because we don't know the information. We have to actually keep it in our differential and make a note to follow up that information to get a clearer picture down the road, which serves as another teaching point, especially for a bipolar illness. The initial psychiatric evaluation should never allow you to say anything definitively. And it's very similar to substance use. Right? Your initial report is a provisional report only, and the clinician should remain flexible with regard to the integration of new information and changing their diagnosis, being flexible with regard to their diagnosis and differential diagnosis. Any other observations with regard to this character? So you picked up on narcissistic traits. Any particular traits that caught your eye?
I think, like, even from like an early age, kind of when he expected himself to like be a credible sidekick, like he had the qualifications, like it's kind of what he deserved. And then like when that was turned around on him, it kind of devastated him. So from like even like a childhood, that kind of happened, and then even his whole plan in the future was to get the spotlight on him, to create a situation where he'd be able to get a star.
Interesting observation. So this is the identification of narcissistic traits, including but not limited to grandiosity, right? And of course, as soon as we begin thinking about this, remembering that narcissism, we talked about this morning with regard to the Jimmy, both the character as well as the title of the episode, that the individual must demonstrate these traits, and the clinician has to reassure that they're not otherwise attributed to another mental disorder. And we already named another mental disorder that absolutely has grandiosity as part of its definition. Having said that, you've identified that his syndrome appears, as Buddy, to have demonstrated these traits prior to his becoming syndrome. And that certainly would be supportive of a secondary illness, rule out the narcissistic personality disorder. So that's the way I would definitely formulate that. And I would definitely leave that in our differential, therefore. And what's even interesting beyond that is something called narcissistic injury. Anybody care to guess what this clinical term, usually used in psychotherapy, of narcissistic injury means?
I mean, I guess
you can't tell because I'm only showing 1% of the time. They're all pointing at each other.
I guess if it's used in psychotherapy, the idea would be kind of just like challenging that belief that they are special.
Right. So the individual, as you just mentioned, believes that they are special and can be only understood by somebody as special as they. And there is a phenomenon in psychotherapy called twinship transference, when the narcissist accepts the therapist as their equal. And if there are any problems with regard to that transference, the result could be narcissistic injury, okay? My traits are largely the product of my not trusting people, and therefore acknowledging that I can only trust myself. And by the way, I am special. I can pull this off. Up to a point where, you know, Doc, you and I, you know, in a lot of ways we're alike, right? Twin ship transference. And it may not be that explicit, of course. And then feeling that they've been wrongly done, resulting in the narcissistic injury. And we see this, right? I could be your sidekick, you know, Mr. Incredible, you and I, in some ways, we're a lot alike, and then being rejected, right?
I have a question. Could the narcissistic traits be an aspect of antisocial, since he does seem to not respect the rights of others? Is he puts everyone at risk just so that he can show that he can save them? It seems like kind of like a silly thing to do just to show off, like he's really leading people's lives. And even the woman who works for him puts her life at risk, even though she's on his side, just for his own selfish gain.
So the observation is that this character demonstrates a blatant disregard for others' rights and safety. And we identify that as the cardinal trait of the antisocial personality disorder. So I think at first glance, we would want to include the antisocial personality in our differential diagnosis. When we get to this point, there's a couple of things now that we have to consider. Number one, how does this particular trait manifest? And again, I would want your feedback, but my impression is that it manifests out of rejection. So it manifests out of his narcissism. And number two, we have to remind ourselves that as clinicians, antisocial personality disorder is a adult-only illness. And I'm not sure as syndrome if he's 18 years of age or older. But if he is, we would need the evidence of conduct disorder prior to the age of 15. And I'm not sure that's there. So, of course, we'd have to investigate. And if there is no evidence of conduct prior to the age of 15, then I think we can look at what look to be antisocial traits, in fact, stemming from narcissistic injury, right? Wanting to be Mr. Incredible sidekick and becoming rejected, and then incorporating those traits as a result. And that's different than personality developed traits stemming from conduct disorder, right? So that's the way I would kind of address the antisocial traits, these very traits that certainly demonstrate a disregard for others' safety and rights. I may mention this before, probably good idea to re-ask this question. With regard to rejection, and who knows, maybe Mr. Incredible is a narcissist as well, resulting in narcissistic injury. And then what syndrome does, is that a recreation of a trope? Have you seen this before?
Can you repeat that one more time? Sorry.
Yeah, it is a little loud. We have to speak a little louder. Rejection resulting in narcissistic and antisocial traits in literature. I mean,
Off the top of my head, I don't know about specific examples, but I feel like that's kind of a common thread in movies with movie villains. I guess.
Or both.
Yeah.
Harry Potter.
Harry Potter, okay. Farther back. The gold standard of rejection. That's it. Right? Frankenstein's monster. Okay, Victor Frankenstein himself a narcissist, believing he could create life. Building, creating life. And then because he believed it was hideous, rejecting it. And then the entire novel depicting the creation's revenge. It is a sad novel, and it's even sadder when you realize that Mary Shelley herself felt rejected with regard to her dad and how it certainly resulted in the sublimation that became the novel. Sublimation is a defense mechanism in which an impulse, I want to kill my father, is discharged in an artistic way. So the individual can discharge, in this case, their anger and their impulse, but in a socially acceptable way that will pass the superego sniff test, right? Called the reality principle. All right, so we have bipolar, we have antisocial traits, we have narcissistic traits, we have rejection and narcissistic injury. Anything else with syndrome?
Could we look into possible stimulant use disorder?
Possible.
Stimulant use disorder?
So we definitely have to talk about substance use. And even though I said no to begin with, I said it was to begin with and it was provisional. I'd be very concerned about the use of substances resulting in what we're seeing here. You know, and I think the reason why are maybe threefold, right? Number one, major observation, we've already been through this. It looks like he has bipolar traits or behaviors, right? That's number one. So we have to ask ourselves the question, is there a substance that can induce those very behaviors? Number two, it looks like he's also on a performance enhancer, right? And number three is the big reveal. What is, spoiler alert, the big reveal at the ending of this movie? Huh? Do you want to leave the room before? What's the big reveal? What does Syndrome disclose at the end of this movie that we probably weren't prepared for? Right? That nobody be super. And he intentionally creates the catastrophes just so he can be in the right place and get the credit for defeating it, right? It's all a sham. So not only would we look at a substance that might be a performance enhancer, but we would also look for a substance that would be a cognitive enhancer too. I mean, he's likely the smartest supervillain. So is there a drug that can induce bipolar, induce mania? Number two is a performance enhancer, and number three is a cognitive enhancer. Because if so, boy, we're going to get the urine drug screen, and we're going to look specifically for the substance.
So like Adderall.
Yeah. Yep. So a stimulant and probably an amphetamine if you want to get specific. Not that cocaine couldn't do it. Not that crystal meth couldn't do it. Yeah. Cocaine, low dose cocaine could be a cognitive enhancer, yeah. I mean, whether it's an amphetamine, whether it's cocaine, stimulants in general are going to work with the same signs and symptoms, the same inducing effect across the board. Now, there are some side effects, like meth mouth, that differentiate one from the other. But yeah, coke at low doses could be a cognitive enhancer. Not nearly as a good fit as amphetamine, such as dexamphetamine, which is Adderall, which is what you said. Right. So that certainly would be at the very top of our list. It checks all three boxes. If he's abusing amphetamines, he can look like he has bipolar. He can certainly have it or take advantage of its performance enhancing effect, and he can absolutely take advantage of its cognitive stimulating effect or as a cognitive enhancer. Checks all three boxes.
How do you approach a patient who's like denying substance abuse, but it's very obvious to you that they are using substances?
So the question about how do you approach a situation in which an individual denies use, but you maintain that high clinical index of suspicion nonetheless. And I assume that there's no objective evidence, right? So I'm assuming that the urine drug screen is coming back negative, but for whatever reason, the clinician continues to strongly suspect substance use. If that is the case, full disclosure with regard to a real informed consent, because as physicians, we are likely to, this is likely to result in a prescription medication, right? And if that's the case, Syndrome, lithium might be on board. the full disclosure here is that the patient is really accomplishing nothing by providing misinformation, because we're at a situation now that if that were to be true, the lithium is going to be prescribed for something that isn't there. If all this behavior is instead induced by a substance, amphetamine, that means that the lithium is not going to help. And the only thing it is going to do is expose the individual to untoward side effects, all of which you're going to review with your patient, including potential kidney damage, thyroid damage, high levels of calcium, and even blood toxicity. So if your patient hears that, understands, and provides their consent, you can still prescribe that lithium. If your index of suspicion is so high, a lot of clinicians will actually just choose not to prescribe and just say that they don't trust the current situation. I don't believe that we're truly dealing with bipolar, and therefore I don't think the medication's indicated, if it really gets to that point. Any other thoughts about Syndrome or The Incredibles in general before we switch over to Stephen King's Misery? All right, Stephen King's Misery. Where do you want to start? Any character catch your eye? You can't tell, my tongue is in cheek right now. Yeah, let's talk about Annie. So, by the way, you heard me mention this the other day. Everybody here has watched Misery. Kudos. And I would suggest that quite possibly most people here are pursuing careers where they're going to be in the healthcare field, right? So what I would strongly suggest is, after one full year doing what you're doing in your career and having worked with nurses, that you rewatch this movie. Not going to tell you why, but when you do, you're going to reach out to me. You're going to text me. You guys have my phone number. You're gonna tag me on a post, and then I'll tell you why. All right, because it's a thought exercise / mind-blowing experiment. There's your teaser. What did you notice with regard, or your observations pertaining to Annie Wilkes?
Well, she definitely, I'll say, displays traits of antisocial personality disorder. Since we don't know her childhood history, we can't necessarily diagnose that, except that you mentioned that there's a prequel. So, I mean, that's, I think, first and foremost.
So not unlike Syndrome.
Not
right?
Yeah.
I mean, we have two characters now, both of whom none of us would have much of an argument against there being a blatant disregard for others' safety and rights, whether it's Paul Sheldon, whether it's all of humanity in The Incredibles. But in the same context, we really don't know much about any evidence of conduct prior to the age of 15 in either of these characters. So a nice parallel here. Anything else?
Well, I guess, I mean, similarly with her behavior, we would want to rule out potential medical, substance use, anything like that. I believe typically with medical diagnoses, if we're not given anything, we assume that if it's a young female, there is nothing. She's kind of a middle-aged female, but probably still safe to assume that there's nothing there. Substance use, nothing really either that I could identify that would cause this type of behavior.
The only concern there, and it is part of the script, but it's not explicit, is that she's a former nurse,
Yeah.
and she might have access. That's a big maybe, though.
I guess we would also want to rule out maybe like a primary psychotic disorder, potentially also mood disorder if we're worried about bipolar.
That's definitely a start. What is their singular behavior? Give me two that disturb you the most or concern you the most.
One would be with her obsession with men and seemed like almost like she was just in a relationship with him of some sort, even though he's obviously not typical. That's obviously more disturbing behavior, because she's literally keeping him trapped there because she's so obsessed with his stories, and I guess because she idolized him as like her hero.
So this obsession she has with him. Right. Along those lines, up until the time that he is in her home, we have to be concerned that she believes Paul is reciprocating her love. I mean, that probably would be the idealization, right? The fantasy. And by the way, because of that, we have another parallel between Misery and The Incredibles in the untoward effects of meeting your idealized hero, right? I mean, Syndrome, Buddy, so long wants to be the sidekick until he is told, I work alone. By the way, Paul Sheldon uses the same line, right? Eerily. In addition to that, we see rejection. And very similarly, we have Annie, who has this idealized vision of Paul Sheldon, the creator. And similarly, she finds out that he is less than perfect. And it starts off with the use of his language. And you could see her break upon the use of that language in the manuscript that, that she gets to read, that he just completed. All of a sudden, this idealized version, it has tanked. And we're going to see the aftermath of that now. To the extent that Annie suffered through trauma, we know that her father died mysteriously, fell down a flight of stairs, and then her husband, and she divorced, which was likely a reenactment of her primal loss, the loss of her dad. She even tells Paul that she just dove herself into his books and lost herself, and that Misery saved her. She actually identified with Misery. And to the extent that Paul created Misery, she worships him as her creator. Okay. Again, Frankenstein motif, because she's going to get rejected. I work alone. And we see, again, the aftermath of that, the reaction to that. Along those lines, there is a particular condition or clinical term we use when someone has the delusional belief that another person, usually of higher status, is in love with them. Any guess as to what that clinical term is? Yep. So, say a little louder. You're with the mask on. That's right. Erotomania. And at this point, we have to be at this. Good job. That is something that we have to investigate here, because erotomania is a subtype of delusion. And very quickly then, I think the clinician would be reminded that in the differential diagnosis, and you mentioned psychosis, is a diagnosis of delusional disorder. Now, delusional disorder has several subtypes. Number one is jealous type. I really don't see Annie Wilkes being jealous here. Number two is persecutory type, right? I honestly don't see Annie Wilkes suffering from delusions of persecution or paranoia. Number three is erotomania. We said that. Number four is grandiose. I am a little concerned here because she does have at least one scene in which she tells Paul that God spoke to her. And that certainly can be construed by the clinician as being grandiose. And then the final type is the somatic type, where a person believes they're infested or is giving off a bad odor, or maybe part of their body is misshapen in some way. Those are the three common examples of somatic type of delusion. I don't see that in Annie either. And then, of course, there are a couple of other qualifiers. One is mixed type, and Annie may actually have delusional disorder mixed, as evidenced by her experiencing both erotomania and grandiosity. And then the final designation, after jealous, after persecutory, after erotomania, after grandiose, after somatic, is unspecified, when your patient's behavior or the content of their delusion doesn't fit into one of the other categories, undifferentiated. So this may be delusional disorder. Now, to be able to diagnose this, we have to first rule out that the context of her delusions are not due to another mental disorder. And we can think about this in a couple of ways. Number one, larger psychotic disorders like schizophrenia. If an individual is suffering from delusions, irrespective of their content, because they have schizophrenia, their single best diagnosis is schizophrenia. Other than delusions, however, there really doesn't seem to be any signs indicative of schizophrenia here. Matter of fact, and we're going to talk about this, I think, in a little bit more detail in just a bit, but where schizophrenia was initially thought of as a cognitive disorder because of individuals' difficulty with executive functioning and planning, Annie Wilkes has a lot of behavior that appears to be premeditated, and that really would count against schizophrenia as the most likely diagnosis. The other thing to consider with regard to her delusion is that maybe it's not part of a larger psychotic disorder, but instead part of another other disorder that is something other than psychosis. And I think the highest yield there would be to consider a mood disorder, because both major depression as well as bipolar can include delusions. As a matter of fact, more than depression, the incidence of psychosis in a bipolar patient is between 40 and 50% with regard to lifetime prevalence. So we're kind of right back where we started with regard to this idea maybe she has bipolar, and what we're seeing is mania. Of course, if she's had this delusion, and it looks like she's had this sustained, that Paul is in love with her outside of a manic episode, we'd have to rethink that. But for now, provisional would be bipolar. But the clinician should certainly want to investigate not only the content of her delusion, but the time frame of it as well. Is it within the context of mania only, or is there any evidence that she has no signs or symptoms of mania? Maybe she's between episodes of mania, but she still has a fixed belief that this author is in love with her. Because if that's the case, there's a secondary diagnosis to make, and that secondary diagnosis may in fact be delusional disorder mixed type.
Where it's very like down, seems depressed, very how she presents in the rest of the movie. And that's like her one scene where she says like, he tries to assure her like, oh no, I do care about you. And so she's like, oh, like, I would feel like that might not be completely true. And that's when she's like starting to plan, I think, their suicide, because she doesn't want him to heal and leave her. So I was thinking maybe that could be two episodes.
Not sure. With regard to her, I mean, she's depressed there. She may have went from a manic state and switched to the opposite pole. The only way we would know is, number one, if she wasn't killed by Paul at the end of this movie and we got to observe her longitudinally. Because if her depression stops with no other signs of mania and she goes into a euthymic state, then we could say, you know what, it looks like in most of this movie she was manic. And then she, after her manic episode, she switched to the opposite pole. And she ends the movie up until the time of her death depressed. That could be true. On the other hand, if she shows that depression, she didn't die, and begins to incorporate manic symptoms again, it could be a mixed state, right? It could be with mixed features. And we would expect that to stop too discreetly and her to get back to her premorbid baseline. So what you're saying is true. Of course, it will depend upon the behavior she manifests at the conclusion or after the conclusion of this movie, which of course we will never know now. Any other thoughts about Annie Wilkes?
Just the fact that whenever she claims first, you think that she's obsessed with Paul, but then she has no problem causing harm to him in order to get what she wants. So
so that's kind of like conflicting behavior because you think she was so like enamored by him that she would do anything to save him, which she did originally, but now she has no problem inflicting the pain.
Yeah, I think both. When he escapes the room, she finds out, and then she hobbles him. I mean, that might be the most iconic scene in movie history that deals with inflicting pain. I mean, everybody remembers the hobbling scene. And then even beyond that, her planned murder-suicide. Very inconsistent with her professed love for him. But again, if this is in the context of a delusional framework, whether it's due to true delusional disorder or whether they are delusions as part of mania, the individual certainly could demonstrate this apparent mismatch of what she says she believes and her behavior.
I know that I'm the one who brought up the antisocial traits, but I'm wondering now, just with talking about that her plan was the murder suicide, would that be would be kind of atypical for someone with antisocial personality disorder, right?
It would be less typical for the narcissist. Certainly, the prevalence rates or the incidence rates of suicide for antisocial are lower when compared to the mood disorders. Yes, and then also lower than individuals afflicted with a psychotic disorder. Yeah. So I don't know if I use the word atypical, but definitely lower than the other two conditions, or at least groups of conditions we've discussed. Yeah. Other thoughts about Annie you'd like to discuss today?
Would you consider borderline?
We'd consider everything. Again, we're talking about another personality disorder called borderline, and very similar to antisocial, the same rules apply. If she demonstrates borderline traits, we then have to take the next step. When I say demonstrates, I mean that she meets 5 clinical criteria defining of the borderline personality disorder from that symptom set. The next step would be to make sure that she continues to be defined by those traits prior to what we identify as the manic episode, as well as after, if there was an after. And if yes, then yes, she certainly would meet the diagnosis, and more importantly, would then benefit from empirical treatments for that particular condition. And if you're ever asked, it's called dialectical behavioral therapy, or DBT. It's a group therapy that adheres to cognitive behavioral principles and peer-to-peer support. So there's some utility in making that diagnosis because of the usefulness of DBT if she's diagnosed with borderline personality. And,
Borderline personality disorder, we talked about syndrome, demonstration of BPD, and also the action drugs. Do we see something similar with something like some antipsychotics or anti-epileptic drugs that she may be taking?
yeah, so I certainly think that there's evidence in this movie to suggest that there is a role of a mood stabilizer. I do. And I know in some contexts we've certainly brought this up, in that there's a major blooper in this movie. Not as many certainly as Fatal Attraction, which is just perfect for a discussion in didactic. But Misery has a major blooper here too, that some of us have already discussed. Any observation what that blooper is? I don't think we discussed it. So you're shaking your head. No, don't put the camera on me. You're right. You're safe. Anyone?
I know that I'm the one that was there, but I'm trying to remember the blooper.
Yeah, absolutely. I mean, the idea that the small town would have Dom Perignon is really against Stephen King principles. He paints the idyllic Americana type town, And to introduce this, $200+ bottle of champagne as something that Annie can just go out and get is probably inconsistent with the Stephen King multiverse. So there's a couple of conspiracy theories as to how she got her hands. And I'll remind you that when this movie is produced, I don't think Amazon is a thing. So there's no drone that's going to be flying into the Wilkes farm anytime soon. She likely left town to get that bottle. And while she certainly could have traveled to Denver, I think there's further evidence to suggest that she had been stalking Paul Sheldon. And if so, she probably was on the East Coast. And it was probably there that she picked up the bottle of Dom Perignon. Right. And if that's the case, and if that's the case, if you want to go down that conspiracy theory, there is an opportunity to actually learn about a particular medication that is indicated in the treatment of bipolar, specifically mania, but also used for maintenance, meaning that between episodes, maintaining the individual on lithium so as to prevent a future mood episode, aka recurrence. And there's also a role of lithium with regard to the depressed phase of bipolar illness, despite the fact that it is not FDA approved. It is endorsed by the American Psychiatric Association treatment guidelines to use during bipolar depression. For this particular condition, Annie's return to her home may have resulted in mountain sickness, for which acetazolamide or Diamox would have been prescribed. And Annie likely would have known that.